Welcome to the Research Hub, where, as you know, we look at topics that could be affecting your health and well-being. And the topics that we've covered so far, we've got the COVID inquiry, Module 1, that I covered last week. And this week, we're going to be covering the COVID inquiry again. And we're going to be covering the Module 2. And this is the website. If you want to find out about the inquiry, this is the website to go to. So we're looking at the UK COVID-19 inquiry. The actual title, the title that you would need to put in for a web search is covid19.public covid19.public-inquiry.uk, and it will take you to this page. So the structure of the inquiry, as I said, it's based on modules. We did module 1 last week. We're now looking at module 2 and the recommendations. The core decision making and policy governance, political governance is module 2. So you can find all the modules that have been completed on the website for the COVID-19 public inquiry. Last week we clicked on the summary, and whenever I wanted to stop it, it kept taking me out. So I've decided that this week we're actually going to view it on YouTube, because then as it goes through, I can stop it, pause it, and have a chat with you if I feel the need. So yeah, we'll watch it on YouTube, and then I can control it a little bit better. It's 11 minutes 43 seconds, so it's not hugely long. But as you know from my streams, I have a tendency to stop and have a bit of a chat about what I think. And I have done a bit of research as well into things like, verify you're human. That's interesting. I'm human, Copilot. Honestly, I am. Okay. So, no, sorry, not that one, that one. So we'll start it. We'll watch together, and I'm going to mute. I'm going to mute my microphone while we're watching, and I'm just trusting that I remember to take it off of mute when I talk to you. Otherwise, you won't know what I'm saying when I'm interrupting the flow. But last week, when I was sharing the COVID module 1 with you, there were echoes through the audio. So I'm a bit concerned about that happening again this week. So I'm going to turn my audio off until I'm going to jump in and have a respond to it.
The UK COVID-19 inquiry is an independent public inquiry examining the response to and impact of the COVID-19 pandemic to learn lessons for the future. It is bound by its terms of reference set by the then Prime Minister Boris Johnson. The scale of the pandemic was unprecedented. The inquiry has a huge range of issues to cover. The chair of the inquiry, Baroness Hallett, decided to address this challenge by dividing its work into separate investigations known as modules. Each module is focused on a different topic with its own public hearings where the chair hears evidence. Following hearings, recommendations are developed and put into.
So one thing I love about this being on YouTube means that I can pause it and you can look at the wonderful graphics. I know you can see the graphics as we're going through, but I do love a graphic. I really do.
A module report. These reports contain findings from the evidence collected across each module and the chair's recommendations for the future. The report for Module 1, Resilience and Preparedness, has already been published. The second set of modules, Module 2, UK, Module 2A, Scotland, Module 2B, Wales, and Module 2C, Northern Ireland, focuses on the core political and administrative decision-making across the UK in response to the COVID-19 pandemic. This has provided the inquiry with the opportunity to compare and contrast the different choices made by the 4 governments in responding to the same emergency and to identify the most important lessons for responding to future UK-wide emergencies. Future reports will focus on specific areas including healthcare systems, vaccines and therapeutics, procurement and distribution of key equipment and supplies, the care sector, test, trace and isolate programs, children and young people, the economic response to the pandemic, and the impact on society. Key findings. The emergence of COVID-19. The initial response to the pandemic was marked by a lack of information and a lack of urgency. Despite clear signs that the virus was spreading globally, all 4 nations failed to take sufficiently timely and effective action. Limited testing capacity and a lack of adequate surveillance mechanisms meant that decision makers did not appreciate the extent to which the virus was spreading undetected in the UK, and they failed to recognise the level of threat posed. This was compounded by misleading assurances from the Department of Health and Social Care and the widely held view that the UK was well prepared for a pandemic. The devolved administrations were too reliant on the UK government to lead the response.
Yeah, they shouldn't have relied on the UK government to lead the response at all. That's looking at all the different regions. So that's Scotland, Wales, Ireland. Yeah, it was a fool's errand to look to the UK.
The first UK-wide lockdown. The UK government's initial approach was to try to slow the spread of the virus. By the 13th of March 2020, it was clear the true number of cases was several times higher than previously estimated, and that this approach would risk healthcare systems being overwhelmed. The UK government introduced advisory restrictions on the 16th of March 2020, including self-isolation, household quarantine, and social distancing. Had restrictions been introduced sooner, when the number of cases was lower?
I agree with this. There's a bit of controversy around whether the COVID-19 was manufactured and whether, I mentioned last week that a friend of mine and I sit in a room and say, oh, there's this little guy in an office somewhere in the government asking what they can make us do next. I don't deny at all that the COVID-19 was an issue. I'm not a denier along those lines. What I call into question and what I argue is if the strain was bad and the government knew the strain was bad, much like this report has said, if they could have turned round to us and given us honesty to start with and said, look, we've got a particularly bad strain of coronavirus, and if you experience any symptoms at all, you need to stay away from other people. If that had been implemented right from the get-go, not March 16th, when the government introduced advisory restrictions, we were knowing about this. They knew that there was a pandemic happening before then. And it would have been very good to have turned to us and said, look, this is a possibility. If you experience any symptoms, just stay indoors, stay away from other people, stay indoors, wait for it to pass. And if it's not passing and it gets worse, then call a healthcare professional. Very simple. If they've done that straight away, and I think that's what the inquiry is mentioned.
This lack of urgency and the huge rise in infections made a mandatory lockdown inevitable. It should have been introduced 1 week earlier. Modelling shows that in England alone there would have been approximately 23,000 fewer deaths in the first wave up until the 1st of July 2020. The inquiry rejects the criticism that the 4 governments were wrong to impose a mandatory lockdown on the 23rd of March 2020. All 4 governments received clear and compelling advice to do so. Without it, the growth in transmission would have led to an unacceptable loss of life. However, their failure to act promptly and effectively had put them in this position. Exiting the first lockdown. When entering the first lockdown, none of the 4 governments had a strategy for when or how they would exit the lockdown. On the 4th of July 2020, the majority of restrictions in England were eased, despite advice to the UK government that this was high risk and infections could spread more quickly. Wales, Scotland and Northern Ireland governments eased restrictions more gradually over summer 2020, increasing the chance that further lockdowns may not be necessary or as restrictive. But none of the four governments gave enough attention to the possibility of a second wave, meaning there was very little contingency planning in place. The second wave. The UK government, Welsh government and Northern Ireland executive introduced restrictions too late when faced with rising case rates in autumn 2020, and they were not in place for long enough or were too weak to control the spread of the virus. In England, despite warnings, the UK government imposed weak restrictions, allowing the virus to continue to spread rapidly. If a circuit breaker lockdown had been introduced in late September or early October 2020, the second national lockdown in England on the 5th of November could have been shorter or possibly avoided entirely. Despite being advised on the
interesting phrase that I kind of half had an idea of what it was, but I looked it up anyway. So a circuit breaker lockdown. I went and asked Copilot, what is a circuit breaker lockdown? A circuit breaker lockdown is a short, strict lockdown designed to quickly reduce the spread of infections, usually lasting 2 to 3 weeks. It's called a circuit breaker because, like an electrical circuit breaker, it temporarily shuts things down to stop a surge. In this case, a surge in disease transmission. So short duration, usually 2 or 3 weeks. Similar to full lockdown. So closure of non-essential businesses, restrictions on gatherings and limits on travel. And it's to reset infection rates, prevent hospitals from being overwhelmed, and buy time for vaccination or other public health measures. The origin of the terms borrowed from electrical engineering, where a circuit breaker halts current flow to prevent damage. So evidence of its effectiveness, mixed results. Some regions saw sharp drops in cases, while others found gains short-lived if restrictions weren't followed by longer-term strategies. So and then it goes through the context of the use. So I was right in what I'd thought. I asked about giving me different countries that have implemented circuit breaker lockdowns, and evidently Singapore did. We know we did, Ireland did, Wales did. So the effectiveness, Singapore's outcomes, short-term suppression. Experts reported community cases fell to fewer than 10 per day near the end of the initial circuit breaker, enabling measured loosening of restrictions. This indicated a clear reduction in transmission during the intervening window. So this is good as a comparison to how we did. Broader impacts analysis noted reductions in cases alongside benefits like improved air quality, reflecting decreased mobility and contract rates consistent with suppressed transmission. And the behavioural compliance, adoption of precautionary behaviours, masks, distancing, limiting visitors, was central to the intervention's effectiveness, illustrating that outcomes depended on sustained public adherence. England and Ireland mixed, but we did have some measurable benefits. So that's what a circuit breaker is, and that's what they're talking about here.
5th of October that further restrictions were needed, the Welsh Government did not implement a 2-week fire break until the 23rd of October. In Northern Ireland, politically divided executive committee meetings led to chaotic decision-making. A 4-week circuit breaker was introduced on the 16th of October 2020, despite advice that a 6-week intervention was needed. In Scotland, the quick introduction of stringent, locally targeted measures in the autumn meant cases grew more gradually, avoiding a nationwide lockdown. In late 2020, the more transmissible Alpha variant rapidly increased cases. Whilst entirely foreseeable, all four governments failed to recognise this threat and did not take action until infection levels were critical. This created a situation in which a return to lockdown restrictions seemed to them to be unavoidable. The vaccination rollout and Delta and Omicron variants. In December 2020, the UK was the first country in the world to approve
the history of coronaviruses, the timeline. So we have early 1930s. We have the 1950s. We have 2002, 2003. And we have September to present. So these are, we've had coronaviruses for a long, long time. A long time. Oh, hang on. Let me just bring me back. There we are. I'm trusting that I'm not muted. No, I'm not. So I wanted to know about the treatment protocols over that time period. So the 1960s, there were no specific antiviral drugs or vaccines for these common coronaviruses. SARS, no proven effective treatments, but various protocols were tried. MERS, no evidence-based pharmacological therapy exists for MERS. No vaccine is currently available. And then for the COVID-19, this was strange. Treatment evolved significantly over time. Key protocols included early pandemic, hydroxychloroquine, and azithromycin. Those combinations were initially used. Then it goes through all the other different drugs that were tried, but he doesn't mention the vaccines. And I said, you haven't mentioned the mRNA vaccines. And he says, you're absolutely right, Sarah. I should have included the vaccines, which were a major part of the COVID-19 treatment and prevention strategy. So we go through the development timeline of the vaccines, which, when you look, look, timeline. Pfizer BioNTech vaccine received FDA emergency use authorization on December the 11th, 2020. Moderna was authorized on the 18th of December. Pfizer received full FDA approval on the 23rd of August, 2021. Efficacy clinical trials showed the Pfizer BioNTech vaccine had 95% efficacy. And as I'm reading all of this, it says how it works. Both vaccines contain mRNA coding for the spike protein of SARS-CoV-2, which allows the coronavirus to enter host cells. The mRNA teaches cells to produce the spike protein, triggering an immune response without using the actual virus. And the evolution of it. As I was reading all of that, I was looking at the time frames, and this is from 2020 to 2022. And it says, by the end of 22, COVID-19 vaccines have prevented 18.5 million hospitalizations and 3.2 million deaths in the United States. And my researcher head was on, and I sat and I thought, hang on a minute, that doesn't make much sense, because I know that in order to bring something to market and take it through the development phase and through the testing phase, there's a period of time that takes place for that. And I wanted clarity. I know roughly how long it is, but I really wanted clarity with it. So I asked Claude, how long on average from conception idea to market for human consumption would an experimental drug take to pass all research and testing protocols? So off he went, and that was what he came back with. The standard timeline is 10 to 15 years. Not one, not two, 10 to 15 years. And Claude very kindly breaks down the process for us. So we have preclinical research. It takes about 3 to 6 years, preclinical research. So the drug is tested in labs and on animals. Clinical trials start after 6 years, and they last approximately 9 years. Clinical trials last 9 years. So that's testing on people. And then FDA review of the new drug typically lasts 1 to 2 years for the FDA to approve them. The full research, development, and approval process can last from 12 to 15 years. And it goes all the way through the individual phases. So the averages are 2.3 years for phase 1, 3.6 years for phase 2, and 3.3 years for phase 3, and 1.3 years for phases 3, and 1.3 years between phases 3 and the approval. Now, there can be expedited pathways. It says the FDA does offer faster routes for certain drugs. Drugs with accelerated approval designation have a reduced clinical development time of 1,100 days, so about 3 years shorter. So that's still if we're giving them a 12-year time, not 15-year for it to be approved, 12 years, that still leaves 9 years of data that would be needed, even under the expedited. Breakthrough designation and orphan drug designation also reduce development times. Priority review can shorten the regulatory review phase. So I then asked, because he says this traditional 10 to 15-year timeline makes the COVID-19 vaccine development particularly remarkable. Doesn't it just? As the mRNA vaccines went from conception to emergency authorization in less than a year. An unprecedented acceleration achieved through massive funding, parallel processing of normal sequential steps, and regulatory flexibility during the pandemic. So I then asked, can you trace the precise vaccine research, development, and approval process for COVID-19? It traced Pfizer. So on the 17th of March 2020, Pfizer formally signed a letter of intent to collaborate. January the 12th, 2020, SARS-CoV-2 genetic sequence was made public. Late April 2020, phase 1-2 testing began in Germany with 12 participants. Phase 1-2 testing in America began less than 2 weeks later with 360 subjects. Late July 2020, Pfizer announced phase 3 testing would begin. So 2020, April was when phase 2, 1 and 2 testing was brought out. And by July, so not even 2 months worth of data was collected before Pfizer announced phase 3 testing would begin, with over 30,000 subjects receiving 2 doses. So that was July, and by November, Pfizer concluded the testing and announced 95% efficacy. And then it went through regulatory approval. It went up. The UK became the first global medicines regulator to approve the vaccine. December the 11th, FDA granted emergency use authorization. Then it goes through the Moderna as well. So I'm going to take that off for a minute and show you this. This gives you a clear picture of the different phases and how incredibly quickly the COVID-19 vaccines were put into place compared to what would usually be a normal vaccine timeline here. It's more than distressing. that it went through so very, very quickly. I'll take that out and add that back. So according to Claude, it represents a dramatic acceleration from the traditional 10 to 15-year drug development timeline to less than 1 year from genetic sequence publication to emergency authorization. I just wanted to make you aware of it. As soon as the inquiry started talking about the different variants and everything else, it really hit me that what I'd said about the vaccines was true. I was called a conspiracy theorist for it. I was called quite a few names. But you can see you can find it yourself when you ask the right questions. How long should a vaccine take to come to market? How long did that vaccine take to come to market? And when you understand that there were only 2 months of clinical trials before they rolled it out to like 36,000 people, there was absolutely no way that they could have had the data back in full to be able to assess whether it was the efficacy was there, which it possibly could have been in the first instance. But the reason that there are those amount of years of data is to see if over time there can be issues. And I suppose you could argue that when it comes to the over time argument, we didn't have time when it came to the pandemic. We'll see. Oh, wrong one.
A vaccine and commence a vaccination program. When the Delta variant emerged in March 2021, all 4 governments had learned from the experience of earlier lockdowns. They delayed planned relaxations to allow time for the vaccine rollout to progress. They exited lockdown by balancing the scale of infection against the additional protection the vaccine offered. The Omicron variant, less severe but much more transmissible, emerged in the winter of 2021. Despite the protection of the vaccine, the sheer number of cases meant more than 30,000 people died with COVID-19 in the UK between November 2021 and June 2022. The approach of all 4 governments in the second half of 2021 had an element of risk. If the vaccines had been less effective, or if Omicron was as severe as previous variants, the consequences would have been disastrous. Key themes have emerged. The need for proper planning and preparedness. This is a constant theme throughout the inquiry. Had the UK been better prepared, lives would have been saved, suffering reduced, and the economic cost of the pandemic far lower. The choices before decision makers would have been very different. The need for prompt and effective action to combat a virus. Governments must act swiftly and decisively to stand any chance of stopping the spread of a virus. Scientific and technical advice. SAGE, the Scientific Advisory Group for Emergencies, provided high-quality scientific advice at extreme pace, but the effectiveness of SAGE's advice was constrained by various factors, including a lack of clearly stated objectives by the UK government. Vulnerabilities and inequalities. The pandemic affected everyone, but the impact was not equal. Older people, disabled people, and some ethnic minority groups faced a higher risk of dying from COVID-19. The increased risk of harm was also strongly influenced by socio-economic factors. Vulnerable and disadvantaged groups were also affected by the restrictions introduced to control the virus. Despite harm being foreseeable, the impact on them was not adequately considered in pandemic planning or when decisions were taken to respond to the virus. Government decision-making. The UK Cabinet was often sidelined in decision-making. Similarly, in the Scottish Government, authority rested with a small group of ministers. But the Welsh Cabinet was fully engaged with decisions mostly by consensus. Coordination of the Northern Ireland Executive's response was weakened by the operational independence of departments, and decision-making was marred by political disputes. At the centre of the UK government, there was a toxic and chaotic culture.
That just stands out, doesn't it? At the centre of the UK government, there was a toxic and chaotic culture. We all know about the toxic and chaotic culture. that was happening in the realms of government when the pandemic was going on. But I think it's really key to remind ourselves. So I asked Copilot, what was the toxic and chaotic culture in the UK government during the pandemic? Okay, the UK COVID-19 inquiry found that a toxic and chaotic culture in government during the pandemic led to delayed decisions, poor leadership, and ultimately tens of thousands of avoidable deaths. Key findings: delayed lockdown decisions, we know about that, indecisive leadership. Johnson was described as frequently changing his mind, being overly optimistic, and failing to grasp the scale of the crisis. Dominic Cummings. His role as chief advisor was heavily criticised. Evidence showed he used offensive, sexualised, and misogynistic language, which poisoned the atmosphere in Downing Street. Sexist workplace culture. The Cabinet Office and Number 10 struggled to recruit senior leaders because of the hostile environment, which hindered effective governance. Chaotic decision-making. Advice from scientists and civil servants was often ignored or delayed, making decisions inefficient and more difficult than they had to be. Rule breaking at the top. We all remember this. Downing Street staff, including senior officials, were accused of breaking their own COVID rules, undermining public trust. And failures across all UK governments. The inquiry noted that England, Scotland, Wales, and Northern Ireland all failed to appreciate the urgency of the pandemic, leading to a too little, too late response. Consequences: the toxic environment created confusion and mistrust between ministers' advisors and civil servants. Internal communications revealed hostile exchanges and misogynistic language, which eroded morale and professionalism. The chaotic culture meant scientific advice was sidelined and political calculations often took precedence over public health. The inquiry emphasised that the toxic culture wasn't just about personalities, it had direct consequences for public health, costing thousands of lives. It also damaged the credibility of government institutions, leaving the public less willing to comply with the restrictions, I should say. The report suggested that future crisis governance must prioritise clear leadership, respect for expertise, and a healthier workplace culture. So that is just a reminder of the toxic and chaotic culture in our UK government at the time.
Public health communications. Controlling the virus was dependent on the public understanding the risk they faced and acting accordingly. The stay-at-home campaign was effective at maximising compliance in the first lockdown, but its simplicity had risks, such as discouraging those needing to seek help or medical treatment from leaving home. The complexity of regulations, localised restrictions and variations in rules across the 4 nations made it difficult for the public to understand what rules applied. Allegations of rule breaking by ministers and advisors caused huge distress and undermined public confidence in their governments. Legislation and enforcement. Confusion between advice and binding legal restrictions undermined trust and compliance and made enforcement by the police practically impossible or legally uncertain in some cases. This was particularly the case where legal rules diverged across the UK. Intergovernmental working. A lack of trust between the then Prime Minister and some of the leaders of the devolved nations affected the collaborative approach to decision-making. It is incumbent on politicians to work collectively in the public interest in any future emergency. Specific recommendations. In addition to identifying 10 lessons to inform the planning for and response to a pandemic, a comprehensive description of recommendations can be found in the full Module 2, 2A, 2B, and 2C report. These are designed to work together with the recommendations from the inquiry's Module 1 report to better safeguard the UK in any future pandemic. The recommendations include improving consideration of the impact that decisions might have on those most at risk in an emergency. Changes should aim to identify any risks to vulnerable groups in both the planning for and response to emergencies. Broadening participation in SAGE, the Scientific Advisory Group for Emergencies, through open recruitment of experts and representation of devolved administrations. Reforming and clarifying the structures for decision-making during emergencies within each nation. Ensuring that decisions and their implications are clearly communicated to the public. Laws and guidance should be easily understood and available in accessible formats. Enabling greater parliamentary scrutiny of the use of emergency powers through safeguards such as time limits and regular reporting on how powers have been used. Establishing structures to improve the communication between the four nations during an emergency, to ensure better alignment of policies where desirable, and to provide a clear rationale for differences in approach where necessary.
So all of this, all of Module 2, just like Module 1, is aimed at what the government need to do and to really drill down on the fact that there are huge inadequacies in the way they treated the public. I mean, last week I pointed this out, the fact that the inquiry is talking to government about the things that they need to put in place in order for this kind of situation to never, ever occur again. And government have to come together across all of the regions in order for it to be a cohesive plan. However, the personalities and the grudges and the issues among the people in our governing body, it's like they can't put that aside in order to actually make a coherent response to anything. So this is not in place for us to work out what we could have done differently. It's in place for the government to understand how they have to pull together in order for a situation like this to never occur again. And if a situation comes up where we face another pandemic, then we're prepared for it. And we can do what I suggested right at the very onset, even if it's a little bit of overkill, to be able to turn around and say, right, if you're experiencing these symptoms, and coronavirus is like flu, it is a flu. It's a seasonal cold, effectively. So if you get a seasonal cold, when we already know that other countries are having rates of problems with that type of seasonal cold, then just don't leave your house unless you're really unwell and need to go to the hospital, and stay in place, shelter in place until it passes. That's all that needed to be said right at the very beginning. And we would have understood that, rather than being forced and dictated to and not given clear guidelines as to why, how, and what. I think the COVID inquiry, this is just spot on so far at telling government where they really have failed. And I do agree that a lot more lives could have been saved if they had just simply said, stay at home if you've got a cold, because this is a bit of an issue one. The coronavirus it's a bit of an issue. So we need you to stay at home if you experience any symptoms at all. If that had been put out clearly, yeah, I agree with the inquiry. Well, obviously, they're professional over it, and I'm just a commentator on it. But that makes perfect sense to me.
The Chair expects that recommendations are acted upon and implemented within the timeframes set out in the recommendations. The inquiry will be monitoring the implementation of the recommendations during its lifetime. To find out more, or to download a copy of the full Module 2, 2A, 2B and 2C report or other accessible formats, visit covid19.public-inquiry.uk/reports.
So there we have it. That's the reports. The toxic culture and chaotic culture of the UK Parliament was, it's almost something that I really don't think the public can come back from. I mean, aside from what was happening inside government, when we found out what had been like parties being had, it just broke down trust. It completely obliterated any trust we have. It became a culture of do as I say, not as I do. And we all know about Cummings giving his advice and then scooting off to see his family. That kind of thing is, once trust like that is broken, it is so difficult to get that trust back. I really genuinely don't know what the government can do to get that trust back. And you can't even say it was, oh, it's Boris Johnson's reign, so we don't trust Boris Johnson. No, like I was saying earlier, it's whoever's pulling the strings of the puppet, that is our government. Starmer now. I mean, I dread to think what would happen if Starmer was faced with the situation that Boris Johnson was faced with. Doesn't bear thinking about, does it? So that's module 2. That's their findings. That's what they've come to the government with, and said that these need to be looked at. These are measures that need to be in place. And if you want to look at the paperwork for that, you can find it. I showed you on this website here, the COVID-19 inquiry website. They do the summary that I'm showing you, because to go through the paperwork and have me just burble all over it, it's probably not the greatest idea. But you can download it. You can download all of the documents to see exactly what it is that they've said. And they have it in easy to read kind of English. So it's palatable. It's not difficult. And they also, if you're deaf, then you can't hear me anyway. But you can, for a member of your family or a friend that you know that's deaf, that's interested, they've got it in British Sign Language too, and they have it just in audio if you fancy listening to it on your way to work. So that's module 2. Last week, when we discussed all of this, I spoke about my concerns and worries about the death rate and the controversies and the speculation over the amount of coronavirus attributable deaths, and whether there may well be, or may well had have been, a culture of recording deaths that weren't actually coronavirus as coronavirus. And when I started that discussion, I showed you this graphic. And if you remember, it's the national statistics. So Statista is the website, and you can go there. They've got some fabulous graphs and charts. And loving statistics, it's one of my favorite places. So this is the death rate, crude death rate in the United Kingdom. It says crude because it doesn't give you all the breakdown of what the deaths are occurring from. And I pointed out that it's from 1953 here all the way over to 2021. So coronavirus hit us here, 2020. And it says crude death rate, deaths per 1,000 population. So at the height of coronavirus, 10.3 deaths per 1,000 of the population. And I also pointed out that the death rates have been really, really, really low since, 2010? But when you come up to 1963, 12.2 deaths per 1,000 in the population. And the death rate really kind of hit those type of highs right the way through to like 1986. So yes, we did have a pandemic. But when you look at this data here and you see just how many people were dying per thousand in those years, much, much higher than we experienced in 2020. And I said I was going to question that. So I have questioned it. And I questioned it with Copilot. So I asked Copilot to give me a graph to look at the change from that period of time. And this is the graph that Copilot gave me. And you can see, I don't know if you can see, because the writing's very small, really. This is the crude death rate and life expectancy between 1960 and 2025. So this here is where the counts were really very high. And when you zoom right in, you can see that the death rate fell. So from 1960 right the way through till 1990, look at how the death rate hit a peak here and then really started to drop. Oh, right. Okay. That's life expectancy for females at the top. So you can see back here, the life expectancy was much, much lower. So it was sitting around the 70s, and it's come right up for women and a little less for men. But it gives you an idea of, Copilot's good to do the statistics and get the information. But when it comes to a graphic, it overlays a lot. So as we lead up to this spike here, where the death per 1,000 is really quite high, we have an aging population, and we have high smoking is what they've attributed that spike to. Then we have cardiovascular disease dominance. So, and the infant mortality started to decline as well. Medical advances and continued improvements over time. So that is the crude death rate and life expectancy between 1960 and 2025. And we have a tiny little blip. And that's it. It's been coming down and down and down and down. And I also showed you this graph where I mentioned about the different, these are the, let me show you, leading causes of death in the UK from 2001 to 2018 by lead group. And I showed you that I was really interested in this one here, influenza and pneumonia, because I had a feeling that there was some reporting going on of deaths from influenza and pneumonia that had been attributed to COVID. So I asked Claude about the historical context from 2013 to 2022, comparing death from respiratory disease, influenza, pneumonia, and to compare those against COVID. So you see this annual death trends. The blue is all the respiratory diseases. This green line here, that goes right the way across, is influenza and pneumonia. And this red line here is COVID. And the first thing I noticed was during the COVID years, here to here, look at the rates of respiratory disease compared to the year before. And the year after. And look at the line of influenza and pneumonia. So when we have the reporting of COVID-19, we actually get a quite considerable dip in the all respiratory disease and quite a considerable dip in the influenza and pneumonia. Again, I am not saying that COVID-19 wasn't a real dire situation, but I am saying that there may have been circumstances that made us believe that it was much more dire than we needed to think it was. So pre-COVID versus COVID era, and this is a stacked comparison. So we're looking at number of deaths on this side, and we have pre-COVID. So that's your respiratory is 72,344, pneumonia 26,342. And then we have COVID. So it went from 72,000, nearly 72,500. In first year of COVID, it went down to 63,000. And from the influenza, 26, nearly and a half, to 20 and a half. Like I say, even if it brought it up to here, even if they had remained level, we still had a large amount of death from coronavirus, according to the general statistics. But there's a dip here, there's a dip here. That went up a little by year 2. Maybe that's when they changed the reporting on the death certificates, possibly. Another really good graphic. Pre-COVID average, much lower, a little bit higher again. Pre-COVID average, much lower, still a little bit higher. Consistent. Then you get the detailed annual data. We won't go into all of that, but suffice to say, what I thought about the reporting has been substantiated in my mind by the figures, but not just in my mind, because Claude had something to say. This is why I asked Claude and not Microsoft through Copilot, because Microsoft may well have given me different information. I could do that search and find out and see if it would give me different information, but I'm not going to do that now. So the key observations, according to Claude: stable baseline between 2013 and 2019, respiratory disease deaths averaged around 71,400 annually, with influenza and pneumonia accounting for about 27,750 of those. The 2020 paradox. COVID-19 caused 73,766 deaths, but total respiratory deaths, 63,141, and flu pneumonia deaths, 20,523, both dropped significantly, down 13% and 26% respectively from 2013 to 2019 average. So it says displacement effect. The drop in traditional respiratory deaths during COVID suggests either lockdown masks reduced other respiratory infections. Some deaths that would have been coded as flu pneumonia were instead coded as COVID, or vulnerable populations who would have died from flu died from COVID instead, which, as we know, we've researched, is flu, where it's a common cold, just a very severe one. Total increase in 2020, despite the drop in other respiratory deaths, total respiratory mortality, including COVID, was approximately 136,897. This is why I say I don't deny that COVID was a particularly nasty strain, because it nearly doubled the pre-pandemic average, the deaths. Recovery trend: by 2022, COVID deaths dropped to 21,573 as it became endemic, while traditional respiratory deaths began returning towards historical levels. And flu suppression: influenza, pneumonia deaths in 2020 and 2021 were at their lowest levels in the observed period, likely due to COVID mitigation measures, masks, distancing, and reduced travel. So there we have it. I've been talking about mislabeling of death certificates and looking at the death certificates and being concerned that possibly there was a reduction in the UK respiratory deaths, and that I would look out the information. Well, I found the information, and there you have it. So it was something that needed to be looked at and needs to be taken into consideration, I think, when it comes to the inquiry. But we won't find that out until they carry on with the rest of the modules, and we'll see if they look at that at all. I hope that they do. But for now, that's it for the Research Hub. Thank you for making it through this far. If you have, well done you. You should get a medal, especially if you've watched the whole live stream. If you want to watch the whole live stream and you're looking at this on YouTube, pop over to Twitch and you'll have the opportunity to look at the entire live stream. But until then, stay safe and stay well.